everybody to your next community of practice. Been moved to be early to fit around my annual leave, so apologies. It hasn't been a full month since we last met. The plan today is I've got two speaking. One is Rachael Evans, who's going to go first, who's a prof in Leicester, who's going to talk about her joint respiratory and cardiology clinic that she does. And then I'm going to talk about the service that we do within Cannock. Now, ours is out of a CDC, but I don't feel it has to be done out of a CDC. It's just showing different ways, different models that people have set up from a breathlessness service. I'm kind of thinking, Graham et al., that we might get going because I don't want to lose any more time. So if we can start recording, and then Rachael, I've done a mini introduction. I'll let you start. Over to you. I'm going to turn my camera off, everyone, while I eat my lunch, ready for my talk, if that's okay.
Well, thanks very much for the invite to come and talk to you about the Leicester service. Let me just get this on the right bit. Right. So I'm going to start with a caveat, and that's that I really don't think there's a right way to design or deliver a breathlessness service. It's more important that we're all doing something, and what we can do probably is a little bit constrained by what we have around us. But there probably are a few key ingredients that we all need to be thinking about. So whenever we're starting anything, whether it's clinical care or research, we need to have a clear vision of what does good look like and who does it look good for. And I suppose for all of us as clinicians, we've absolutely got patients right at the centre of things. Obviously, the NHS also has to do things in a clinically and cost-effective way. And actually, breathlessness pathways, if we do the right thing, actually it's good for patients, it's enjoyable for clinicians, and actually it is really efficient for healthcare systems. So it really is win-win-win. And I know that I am speaking to an enlightened and probably many of you can teach me things. Sorry, was somebody?
Yeah.
Oh, it's just someone on the phone, is it? Sorry, I thought somebody was asking a question. So what does good look like? To begin with, and we're probably not quite in this space, but we need to have somebody that seeks help early. And there is research going on to try and target who is at risk of breathlessness and reach out to them. So actually trying to be a bit more proactive. Certainly our peer support groups can help with that as well. We want to get an early holistic diagnosis, and that's where we're all sitting. But that diagnosis then needs to lead very quickly either onto, or not either, to both early disease-specific treatment and then personalised breathlessness management. And then at the end of that, hopefully the person feels better, lives longer, less cost to the healthcare system. And underpinning all of this is that we run breathlessness self-management throughout. So many of you will know this data, but just to remind us that there are delays to diagnosis for really common serious conditions. So picking out COPD, heart failure, ILD. And these delays aren't in terms of days, weeks, months, they're in terms of years. So we're not in a good place where we're starting from. So anything we can all be doing to kind of reduce those delays to diagnosis, the better. And we also need to be improving the accuracy of our diagnoses. As you can see at the bottom of all of these snippets of information with a few key papers for you if you want to dig into the data a little bit more, is along those delays there's also misdiagnosis and inaccurate diagnosis, and that obviously leads to the wrong treatments and patients not getting better. I think one of the key things to really flag back up to NHSE is that still these common chronic diseases are getting diagnosed in hospital. In the case, the cohort study around heart failure on the top right of your screen, 79% of patients actually presented and got their diagnosis of heart failure in hospital. And that data's not that old. It was from 2018. So that's staggering to me. And the same in COPD, it was over 40% got diagnosed when they were in hospital. And that's despite these patients being seen in primary care, pharmacists, secondary care, multiple times beforehand. So there's a lot of space for us to do better. And these delays are important. So this is some healthcare data from CPRD, primary care data, and over 100,000 people that had a code of breathlessness. We picked through it to try and find who we thought could have chronic breathlessness as well as we could tell in a healthcare record. And we divided them into the time to diagnosis between less than 6 months, 6 months to 2 years, and over 2 years. And those are people that were diagnosed within 6 months had a better overall prognosis and less hospital admissions and a longer time to their first hospital admission. So why is it difficult? Well, all of you know when you get presented with somebody with breathlessness, there's a whole myriad of things that could be wrong, and it crosses multiple symptoms. So whereas some symptoms are really key, only located in one system, breathlessness affects the brain, heart, lungs, chest wall, skeletal muscle, everything. And so people can end up in the wrong place in the healthcare system if we don't get these pathways right from the beginning. But the good news is there's things that we can help support our primary care colleagues with. 2/3 of people have got chronic respiratory disease that present with breathlessness. And then there's key other factors. So obesity, deconditioning, anxiety, depression, anemia, hyperthyroidism, probably more common in primary care than we see in secondary care. But these are common conditions with simple tests that can exclude them. I've labelled obesity, deconditioning and mood disturbance here as contributing factors. Everyone can pick away whether you want to call it a disease or not. I think we just need to recognise that they can contribute to breathlessness and have a skill set of what to do about them. And the same for those other causes. And as you know, none of these things are mutually exclusive. They can all occur in the same person. So breathing pattern disorder, inducible laryngeal obstruction, and then excessive dynamic airway collapse, which I think most of us don't see that commonly, and that may be because we're not looking. So that's what I would call, if you've gone through all of those things, you've got what disease is happening, if at all, what contributing factors are dominant, and what other causes are happening. If we made that multifactorial, multifactorial diagnosis, we'd get much better holistic treatment to the person. But we've stuck with these very disease-specific services. So back in 2014, I think, originally, there was NHS Innovation Quality or something like that it was called, that had a pilot project around breathlessness pathways even then, and that's where the clinic at Leicester came from. So we had a look at, well, how can we get an integrated symptom-based pathway using breathlessness as an exemplar. So we looked at, well, what actually happens to patients with breathless currently coming into secondary care, and we did a quick survey across our cardiology and respiratory outpatients. We found that 1/3 of all referrals were for breathlessness. 60% had unexplained symptoms, so no known condition. 35% had either one investigation or none before referral, and that includes just a simple blood test. They were waiting over 13 weeks and waiting nearly 20 weeks for physio. And secondary care could be a little bit critical about ourselves as well. Cardiology would do up to a cardiac MRI, a CT angio, goodness knows what else, wouldn't have spirometry. And we found letters saying the problem isn't the heart, so just refer to respiratory. And respiratory, you'd go up HRCT thorax, PFTs, even a CPET, but no BNP and no ECG. And comments like, the lungs appear to be working well, discharge back to the GP. And poor GP sat on the other end going, but I asked what was the cause of the breathlessness, and the patient's there, but I'm asking, is it something serious and what can be done to help? So there's quite a mismatch between what in secondary care we felt we were doing well and what our purpose was, and what primary care and the patient's purpose was. So we all got together, very similar to, I expect you all have, to actually find out who our team is. And actually we found a lot of people that were interested in breathlessness and a lot of people that really wanted to do the right thing. This was a process called Listening into Action that our trust was running at the time, and we put together our breathlessness pathway. Now, although there's lots of boxes on here, I still think the most important thing on this slide is that focus, history and examination, and giving somebody time to really do that with the patient. I will then, after saying that, talk a lot about investigations, but I don't want that to distract from the fact that this is the key thing. We put together the investigations, which look very similar to the NHSE diagnostic pathway, but where actually over 50% of those diagnoses that I showed you on that early slide can be made or excluded confidently by this simple panel. And these are those key 5 diagnoses. And we said if we've got high diagnostic confidence, then we would literally in primary care just refer to those disease-specific pathways. So if you find COPD, if you find heart failure, crack on to the right pathway. There's low diagnostic confidence, whether that's clinician or the patient also isn't secure with what they're being told, then they can refer into the breathlessness clinic. So the breathlessness clinic in our area very much sits between primary care and say secondary care, cardiology and respiratory. It's sort of in between, even though we actually conduct it in the hospital. So the history, I think one of the most common things I think that gets a little bit confused is breathing pattern disorder, asthma, angina, and there are clear differentiators for a lot of people in the history, but there still are some where, I come away thinking, well, it might be this, it might be the other. But we should always remember to assess clinical risk. And I had I'm going to say young man because he wasn't too much older than myself, come into clinic with a strong family history of coronary artery disease, hypertension and hypercholesterolemia, but a history of breathlessness, non-smoker, not diabetic. And the GP had wondered about breathing pattern disorder. But the history really was exertional breathlessness. So, and that clinical risk really was pointing towards needing to make sure this wasn't ischemic heart disease, which in the end it turned out to be. So I think we just really have to have our heads on to think everything in that history, everything in the risk factor profile of how we can improve our pre-test probability of what comes next. Mustn't forget the physical examination. Sometimes in primary care, we know there's a lot of phone calls now, but there are key findings that we won't find on tests. The clubbing, the cyanosis, chest wall deformities, actually, I think it's probably one of the most common things that hasn't necessarily been explicitly mentioned in a referral, and you see somebody and they've got clear kyphoscoliosis. Perhaps it's not been seen on the chest x-ray for whatever reason. Aortic stenosis and other murmurs. I'm just picking aortic stenosis because clearly there's a pathway where we want to pick that up for intervention or monitoring. And fibrotic crackles of ILD. I think chest x-rays we learn more and more are not that great for subtle ILD. You can have quite a lot of ILD with still a fairly normal chest x-ray, normalish. So in our pathway, all of those basic tests are done in primary care, and I expect that's really the equivalent of tier 1 on the breathlessness pathways. Then they come into a clinic where there's a cardiologist and myself, a physiotherapist, and we do use a lot of cardiopulmonary exercise tests. And by doing this before instead of going either down cardiology or respiratory for breathlessness, actually we managed to reduce that time to diagnosis, and there's a few facts on the next slide, reduce the time to discharge back to the GP, and that patient getting a secure diagnosis and management plan, and increased the proportionate discharge back to the GP after just one appointment. Now, I have to say, COVID pandemic did disrupt a lot of that without being able to get spirometry in primary care. So our waiting list has gone up some. And then the usual pathway is that once we've found the diagnosis, there's a lot of referring on to exercise rehabilitation, a lot of referring to the physios for breathing control techniques, and then they get they're discharged from the GP. There's probably, back to the GP, there's probably about a fifth of people where I do need to do further tests and they come back for further follow-up. And just going back to that original screening of the clinic as was before we set this up, nearly a fifth of all those referrals had actually gone to the incorrect speciality, i.e. the disease was in the other system. And actually, if we'd have just done that simple panel of investigations in primary care or community care before deciding which specialist, actually they could have all been diagnosed. There was a lot of COPD and asthma in that mix that actually could have been diagnosed earlier, and they were quite straightforward cases. They weren't where they were really complex. And then between us, we felt that actually there would have been another third where they would have gone to the other specialty if we hadn't have had this quick MDT where we discussed everybody that we saw for the pilot. And we saw a lot of multimorbidity, which I'm sure you're all finding in your pathways. That it's actually really quite rare to only have one cause for the breathlessness at the end of all of that. I'm probably not going to talk too much about CPET because that's a talk in its own right, but essentially I'm very positive about doing exercise tests. I think we need to bring them earlier in the pathway because of the level of deconditioning that we see. And also I think that the exercise test itself has therapeutic value. It can show people actually what they can do. The amount of people that say, gosh, I'm really surprised how much I could do. And in really basic terms, we look at, have they made a good effort? Is it a good test? Is it within normal limits or not? And there's some flexibility about that. Why did they stop? And then how did they actually get there? What is the physiology? And there is some pattern recognition that we can use to know whether people have made a good effort. And very briefly, and not to go into this in any detail, but we can look to see whether there's a ventilatory limitation to exercise. And that's really important for things like where you've got an elevated diaphragm and you're not sure how much that's contributing to the breathlessness, whether we should go on for, a diaphragmatic pathway, for instance, or particularly chest wall deformities that can be quite helpful with. And then whether there's a cardiovascular limitation. And I think most of us are always worried about that young person with pulmonary hypertension that perhaps we're missing. I have to say, I'm still yet to really find many of them in the pathway I've been running. But obviously that is one reason why we're running it. But again, I think there's therapeutic value with doing an exercise test for some older people where they've been worried about the heart. The investigations we've done haven't shown any issues. Actually, most people do seem to be very reassured when you've actually done an exercise test. Now, I will remove this slide from the ones you're getting because it's not published yet, but this is some research that a brilliant group in Sweden have done where they've had 30,000 people that have had every single test. So it was a research study. Every patient had every single test, and then they put it in, and this was in people MRC, like the old MRC scale 3 to 5. They put it into an algorithm to say, well, which tests got to which diagnoses the quickest. And as you can see, if you front load that algorithm, spirometry is absolutely right at the beginning of all the pathways. The pathways were for women, men, smokers, not smokers. So we're doing the right thing by bringing in spirometry early into primary care. And actually lung CT and transfer factor are then the next most use, all the way to the other end where actually it's the minority of people that really need that evaluation for ischemic heart disease. Now, I'm not for 1 minute saying that we put a person that we see into an algorithm and say, this is what we should do to investigate you. Of course, we need to use everything that we normally use around pre-test probability. But when we're setting up services and thinking about, well, who do we need in them? Certainly my experience is I want the expertise of a cardiologist. I feel less wedded to the fact that I need one sitting in with me every single, I don't mean physically in with me, but, you know, within the clinic every week. There's far more of a proportion of respiratory disease. So actually our cardiologist does a clinic every other week to my every week clinic, and that works well. Now then, after the diagnosis, I do want to make sure that, and those of you that have been on a couple of calls, I'm sorry if I'm sounding like a stuck record around the fact that the diagnosis only gets us so far, and then clearly we need to do something to help with the breathlessness. And as I said, a lot of people that we see through our clinic, they've got a raised BMI, they're really deconditioned. Actually, there isn't a cardiovascular or ventilatory limitation to exercise. They just need an exercise program. And we did some early work, this was part of my PhD, showing that you can combine exercise rehabilitation for people with COPD and people with heart failure. They actually get most of their mechanism of benefit is actually through what happens to the skeletal muscle. The lung function, as you know, in COPD stays much the same. There's a tiny bit of LV remodeling in heart failure, but again, the predominant benefit is to the skeletal muscle. And we've run combined breathlessness rehabilitation at Glenfield for over 10 years. So all my patients that come through with a raised BMI, deconditioning as the predominant diagnoses, do then get offered an exercise rehabilitation program. Where they've got, where their fitness is reasonable, but they're inactive, then we refer them on to whichever tier in the community that that the obesity diagnosis links into. So that's also reasonable. But most people coming through the clinic, their MRC is at least 3, and actually a formal rehabilitation program has, you know, definitely improves things. Have I done the research to 100% show that and show that it's not just clinically effective, cost effective? No, but we are on the case around that. And right at the beginning, I said that underpinning supported self-management, and Helen on the call was really clear on the NHS England diagnostic pathway that management runs along there. So how do you actually manage the symptom itself? So in the clinic, most people come with, is there anything serious? Well, hopefully we've addressed that. I want to do more, what can be done to help? Hopefully we've addressed that with exercise rehabilitation or whichever physical activity programs you've got access to. But it's distressing what can be done to help. That's when we need to think about that thinking, breathing, functioning modelling that Anaspathes has designed. Simple advice, soften and dropping the shoulders, box breathing or rectangular breathing where appropriate, using a handheld fan, a way in. Have you ever felt the need to open a window or get fresh air? Now, I used to give quite a lot of that advice on a Monday morning in my advanced COPD clinic, and rarely actually used it on a Thursday afternoon in the diagnostic clinic. And I suppose working with the palliative care team has really made me alter that. Now, it's not for everybody, but there are still some people in the breathlessness clinic that are really quite severely disabled by their breathlessness and definitely report benefit of using a fan. So very quickly to finish, we then try, so we've got this breathlessness toolbox that we're trying to personalize their breathlessness management to their traits. So the disease specific therapy I'm not concentrating on here because a lot of those, the people with COPD, heart failure, ILD, they've probably been diagnosed earlier in the pathway and gone into a different pathway. So I'm now focusing on the ones that come through to my clinic where those initial investigations have all been clear. So where it's predominantly deconditioning, they go off and do exercise rehab. where the diagnosis is breathing pattern disorder. And I'm getting many more referrals now with GP saying, I think this is breathing pattern disorder, but I'm not sure. And there's no physio in the community and there's no diagnostic test in the community. So we are trying to develop things that diagnostic tests that we can use in primary and community care as part of research. But that is a key thing in clinic, that the physiotherapist is actually in clinic with me. And I think that is key when you're talking about this condition that people are not really expecting. Being able to just walk them to the person that's actually going to start giving them the treatment, you get such better buy-in that way. And then anxiety and depression, we link in with our local IAP team, which happens to be delivered by Vita Health in our region. So that was just to make sure that I've covered the treatments. So in summary, I hope that's nearly to time. Early diagnosis matters. I don't think I need to really explain that to anyone on this call, but it does need to be linked to appropriate treatments. Key ingredients, we talked about pathways. I think it is that time for a healthcare professional to really go through the history and examination. So that's the bit that I don't want us to lose sight of in any of our pathways. GPs quite often don't have very much time at all to do this, and a panel of investigations is great, but only when you've got the history to really do the interpretation. I think linking to those disease-specific pathways in primary care and community care is key, so they don't even need to hit the hospital. They can just go into what was already existing in the community, and only where it's unexplained after those initial investigations do they really need to come into specialist care. The MDT is clearly important, and that holistic diagnosis matched to holistic treatments. You can all wake up now.
Thanks, Rachel. That's great to hear. Some the background and the treatment, the diagnosis, but also, like you say, the different setups, because when I talk about mine, it's a very different setup to others. Has anyone got any questions for Rachel? I will ask a question if others are maybe thinking about it. How do you get your cardiologists involved? Because I went to speak to a friendly cardiologist and I was told, sorry, we haven't got the capacity, which I appreciate is an issue. And I would suggest you have to find the right cardiologist to be involved. Maybe there's a little bit of luck there. I can see Anne-Marie and Rachel both smiling at me on that one and nodding. Yeah. Rachel, what are your thoughts?
Absolutely. No, it's like, where you've got a little scab, you can't see it anymore, but you're really picking it there, Helen. So I started this with the wonderful Will Nicholson, who is now our head of service, thank goodness. Unfortunately, our trust didn't pay him for a year, so he found something else to do. But so Will is a heart failure specialist, and I do think the heart failure team, they're so physicianly, they get this, they are the right people, but they're just overstretched. So my own experience is that I had a very experienced registrar for a time who did it as an extra session, and then I've gone from locum consultant cardiologist to locum consultant cardiologist because nobody really sees this as their bread and butter. I don't want to make too many. I am going to now make an aspersion, but it's not that an interventionist couldn't do this, but it's not their work. That's not where they're coming from, and we don't need them. I'm perfectly capable of diagnosing coronary artery disease, and when they tell me there's a massive block, I send them off, and it's rare. So it is getting the right person. And similarly, I think an ACP, in either, it just happens that I'm from respiratory, I think it doesn't, I think you just need somebody with that skill set. At the same time that I developed this work, there was this fantastic group of nurses in Wigan that had actually done it themselves. Now, if you'd have asked me at that time, I was like, oh, you need consultant oversight, But actually, I think more and more you need experienced people and experience that know what they're looking for here. Yes, a bit of oversight from somebody. So,
Yes.
Somebody interested in physicianly type medicine, and definitely looking across the field, you know, whether that's pharmacists, physiologists, physios, nurses. I think there's a lot of skill set there, particularly around managing breathlessness that can be utilised.
Thank you for that. Before I go to David, I was actually going to ask Anne-Marie, because she'd been nodding at me as well, because I've only got a few cameras on. Anne-Marie, did you want to talk through your cardiology, kind of how you managed it as well?
Yeah, so I've just put it in the chat. It was similar, really. We started with the cardiologists and the heart failure team. And when we did some of our pathway mapping of kind of looking at what existing pathways were like for these patients with breathlessness, that was one of the bits where we got the most traction. So we did that. I think I shared it last time, the mapping around breathless patient journeys and all that planned and unplanned activity. That was particularly with people with multimorbidity, with heart failure, and usually some COPD, but other bits. But just to echo Rachel's point, that the heart failure part of cardiology are probably the easiest place to start. And then we were just particularly lucky that our CD in cardiothoracics, who sits on our MDT, he gets it. But I think the bit about pulling it into the RTT and performance side of things can help other cardiologists get it when you do some of that mapping around heart failures, because some of those patients have some of the highest activity for planned and unplanned care across acute trusts.
Thank you for that. And I can see Shiv is on here as well. Now, I know very well he has a very dynamic, vocal cardiologist who we previously had talking, who's made contact with me. Actually, I haven't replied to him yet. And just, do you want to talk through your cardiology bit?
Yeah, I mean, I think as I said, heart failure. He's a specialist in heart failure, and he's very keen. And we're trying to bid for the pathway development. And actually, Rachel, I echo your comments about how the patients pitched into cardiologists and then going to come into respiratory. And this is what is happening. I think it's a lot to learn from you all, what you've done. I think I'm keen to get on this going. And is it possible if I can privately contact you about the funding stream? I think we discussed last time with Graham and David as well when I brought it up, because we are up and running, we got the workforce to deliver, but how to reshape the model, how to pitch into the integrated care to the ICBs and utilize the CDCs. That's where we want to establish our service.
So you were asking about contacting Rachel about it?
Rachel and Anne-Marie as well.
Yeah.
I mean, is that the way to go forward?
If Rachel, is that okay?
Yes, but you'll be disappointed with my answer. So
okay,
Shiva,
that's right. Okay.
Because this was all set up. So I've so locally we've made no traction with the community diagnostic hub with our trust, nor with the ICB. So we're just still on the coattails, really, of having done this 10 years ago and it just being embedded in the trust. So I've not had to go out and get it commissioned again. Originally, it was commissioned for a complex clinic with an MDT, because even though we see patients separately, you've still got the joint MDT working and the CPET, so it was costed at a slightly higher tariff at some point. And to be honest, I don't unpick how it's being costed at the moment. I just keep trying to so please don't share this recording with anyone that's in my trust or ICB. You'll get it all dismantled. Yeah, so Shiva, sorry, I'm very happy if there are other things to discuss, but yeah,
thank you.
It's not being newly commissioned.
Thanks, Rachel, for that. But Anne-Marie definitely, I'm sure, would be contactable. And I'm going to Shiv talk about R1 as well in Cannock. So hopefully we'll mention about the funding. David, you've been very polite. Question.
That's all right. Two questions. I think some may be answered. What one is what's your proportion of cardio, like heart failure patients you're seeing compared to coming into MDT compared to respiratory? You said it was mainly respiratory. I just wonder if you have a feel for the percentage. I'm not sure if you flashed the slide up and I didn't see it as I was writing some notes.
So just remember that the clinic, or not just remember, I should have stated more clearly, this clinic is sort of sitting beyond the kind of tier 1 investigations that would have been done at the hub. So actually, I shouldn't, if the pathway is working well, I shouldn't be seeing any heart failure patients, because the BNP will have been done in primary care and they would have had an echo and gone off to the heart failure arrow. Does that make so? The clinic I'm seeing, we've got rid of COPD, asthma, and heart failure.
That's fine. Yeah.
So got rid of that's terrible phrase. You know what I mean?
Triage. Yeah, that's okay. And then my second question is probably related to what Shiva was saying. You know, about the funding and getting it off the ground. I just wondered who was it you spoke to, and what data did they potentially need to say yes?
So it was done as an NHS IQ pilot. So they gave us 15k. Never has money been so well spent, I think, as we're still going. And we presented that data of the scenario we're in back to our managers, and they were aware. There were a few other, so the data is buried in NHS England in a consultant-to-consultant transformation it was used, and another case study. But I think people in our department, the managers, were really worried about this ping-ponging that we kept having between cardiology and respiratory. And that was really caused by a lot of the people that don't have a pure cardiology or respiratory diagnosis. It's all these other things that are contributing to their breathlessness. So by trying to diagnose the diseases earlier and get them in the community, then diagnose ILD, complex COPD, complex heart problems where you really need the specialty, and then have a clinic where you see everything else and actually deal with the symptom itself. That's sort of how it's structured.
Well, thank you. Right, Rachel, thank you very much for your time. You're obviously very welcome to stay, or if you need to go elsewhere, then by all means, but thank you. Right, I'm planning to do the next bit, if that's okay. Graham's in control, or Sarah, with my slides. And my plan is to talk you through the service that we have as well. Now, if some of it's going over what Rachel said, I will skip through that rather than we do. Is that becoming a slide? Slideshow? It's taking a time. So at the moment we've just got the slides rather than slideshow. Are we able to press the bit at the bottom?
Should be on, but
yeah, that one. That should make it a little bit bigger as well.
Is that done there? Are we still on slides?
Yeah, we're still on slides, not the slideshow.
Try again.
Bear with, we'll get going in a sec. Yeah, perfect. I can already see some of mine and Rachel's are quite similar, so that's fine. Is that the second slide? Yep, that's fine. I'll carry on. So for those who don't know me, I think most of you do, but where I'm working is the Royal Wolverhampton NHS Trust. And I want to talk through our breathlessness diagnostic pathway that was set up in light of the NHSE toolkit that was part of the group that kind of developed that. Rachel's already mentioned about delay in diagnosis, thereby impacting management and incorrect diagnosis. So I won't label that point anymore. But if we can go to the next slide. Yeah, and the common causes we've already mentioned as well. Just to mention, 2/3 due to cardiorespiratory disease. The pathway for us is right early on with people who don't have diagnosis. It's much earlier on than Rachel's is. 50% is due to, in people over 40s, due to heart failure, COPD, obesity, anemia, anxiety or depression. And multifactorial is about 1/3 of patients. It feels a lot more than that, but it's quite important to be aware of. Next slide, please. And that's kind of adding to those. So that's what we've just mentioned. Thanks. Next. So locally, obviously we know COVID broke our lung function services. Access to spirometry is quite limited. We did do car park spirometry for a while, but that's now stopped. But realise that spirometry alone isn't everything we need to be able to offer, and currently we haven't got the same offer that we did have pre-COVID. And even people with normal spirometry can go on and have abnormal full lung function tests, gas transfer, lung volumes, etc. So at the time, our direct access spirometry service was oversubscribed, and 40% of the referrals coming into the direct access spirometry service were due to breathlessness query cause. And as we mentioned, COVID kind of led to significant delays and GPs increasingly referring in for lung function. Next, thanks. We developed, it was the time of community diagnostic centres. Our community diagnostic centre is Cannock Chase Hospital, which is interesting, isn't it? Because they tried to avoid hospitals if possible, but it was set up. It's a small hospital which mainly does outpatients. It's got about one inpatient ward and does kind of endoscopy, rheumatology, lots of other clinics. We got NHSE approval and funding, so there is direct funding coming through for CDCs for investigations. We've just managed to be successful in the second round, which is to extend what we're offering at the CDCs, including children, young people, lung function tests, which is a major issue and a major shortage. So we started our diagnostic pathway from November 23, so it's been going on over 2 years now. Next slide. This is the toolkit that's available. This talks about the different tiers of when and how we investigate, and we kind of based our pathway on this toolkit, which is available on the internet with a nice NHSE breathless pathway. Next slide. So our plan was to have an MDT approach. It's a small MDT. It's myself as a consultant. We have the clinical scientists and we have a kind of admin support, and we have a cardiologist go-to that we've befriended and brought in, but don't ask too much of her. But she is massive support of kind of not wanting to do further investigations if we can avoid it. For referrals coming through, we've got breathlessness service performer, and for referral into the service, we've got referrals via the ERAS, which most referrals NHS want us to do, and we take in from 2 ICBs. Now, interestingly, as CDCs, we can bring in outside of our ICBs, but we focus on our own. So referral from primary care, the clinical scientist reviews the referrals. We've got a diagnostic bundle, ideally, that we like to be done before referral, but we don't decline them if they haven't been done. Clinical scientist leads the consult, navigator monitors results, and then we discuss MDT as how our format runs. Next slide. So appropriate referrals are anyone with chronic persistent breathlessness more than 8 weeks, not known to have a diagnosis. So, and we haven't really declined anyone. So they're the main things. Any acute issues, obviously is the ED, but we haven't had the issues with that. Next. Inappropriate referrals, anything acute breathlessness, chest pains, red flags. We did talk about incomplete or inappropriate referral forms being rejected and returned to referral. We tried to accept, do what hasn't been done and feedback rather than reject. Try and develop that relationship, I think, is really key. Next slide. So pre-referral management, the ideal, and it's very much similar to Rachel's and others. I would assume that if someone's been seen within primary care with breathlessness, there'll be an initial some investigations to kind of see if there's anything obvious that can be looked at that point. But with the understanding, all of the tests are done in different places, different times, and can take a long time to be done. ECG is helpful, blood tests that we talked about, including the BMP, chest x-ray and spirometry. But again, if we're going to do spirometry again, I wouldn't necessarily expect it to be done first before it's referred, but we keep an eye on how much of those are done. Next slide. This just outlines where we sit. So it's quite difficult when you start and you have to do it by the ERAS that our referral, our breathlessness pathway is found under CDCs and not respiratory. So once GPs know where it is, then they can do the referrals, but it's navigating them to start off with is quite important. Next slide. And that's where we sit there. Next slide. This is our referral form. So basically it's some information The other bit it has on there is saying that referrer is happy for us to give salbutamol via MDI, so it's that tick off from the clinical scientist point of view, any assistance that needs to be done, a very brief kind of tick box from a history point of view and a clinical history, and obviously from primary care they can print off their electronic records, which might go for that. We advise what we would ideally like to be done, but again, we will pick these up and we're set up. We can do all of what they haven't done on the day, so it's not additional steps for the patients. We do try to just consider those who might be coming, people with dementia, learning disability, physical impairment, for we can think about whether tests are going to be right for all. And then we just think about how breathless they are. That's trying to just give a brief amount. It is embedded within EMIS. It's not having to spend a lot of time doing. We've tried to get it so that some of the information is pulled, so it doesn't have to be done separately as well, because as I'm very aware and married to a GP, if you're going to give them another form to fill in, they have enough work to be. They don't have time to do SBA and clinical admin's time. So we need to make it as easy as possible. Next slide. So route referrals we take from primary care, that's our main route, but we've also got a CAS clinic that we discussed at the last community of practice, which is where 3 respiratory consultants triage all their referrals coming in, and if they see anyone with undiagnosed breathlessness, they will put them and push them directly into our service. And I've had a couple of people who have come to me and said, I've got someone with breathlessness, I'm discharging, I don't know the cause in ED. I will also bring those through as well, but they're less of them because we're not set up in that way. I'm going to suggest, bear in mind we've got about 40 patients waiting to be seen on this pathway. I don't want to completely overwhelm it. So primary care is our main, and respiratory consultants, which massively helps the referral to treatment time because it's less patients waiting to have to see them. Next slide. Yeah, there we go. This one was done beautifully. Right, so test wise, when people come now, everyone gets spirometry, but actually we decided to do full lung function tests on all. Now, CDCs, yes, have got a specific tariff matched, but actually spirometry by itself doesn't rule things in and out, and I really need that gas transfer to know what's happening. Static lung volumes, we do capillary blood gas and oxygen saturation along with FeNO and bronchodilator response depending on the spirometry results. So there are initial lung function tests that we do, which are really helpful. I think there's more on that slide here. So we do the BMP, X-ray and ECG if they haven't been done recently, or pull them if they already have been. And if we press again, so there are other services across the country actually who do CT scans on every single patient who comes through. I have a feeling the cardiologist would hunt me down if I did that. There is no capacity for that. So to be fair, and I'll come through the number we've done CTs, it's minimal, and I only do it if we actually have to. Only referred a couple of people on for echo, to be fair, because I have a feeling BMP is helps take out people going to cardiology first before they come through our pathway, but echo I haven't had to do much of, and we increasingly use more cardiopulmonary exercise tests, which is a test which I'm finding tells you a lot in one sitting, but obviously the availability of CPET, it varies depending on which department, but increasingly it's very helpful for these kind of patients. Next slide. So the patient is seen by clinical scientists. Our band 8B who runs the show, excellent. I'm very lucky to have an Andy, as we're all probably lucky to have certain people in our services. We went through history and what needs to be taken, and he's currently going through his higher specialist scientist training, so we'll end up being consultant at the end of this. So he does a history. Examination, he listens to chests, looks at ankles, etc., but there isn't a doctor with him when he sees, but I haven't found that an issue so far. But the history is really important, and when we initially started we weren't doing that either, and I'm sorry, but you need the history to support what you're doing. Previously we had him doing the whole appointment, including all the lung function tests. You do the history, do the lung function tests and see it all through, and that was a 90-minute appointment. But with the demand going up, we've reduced that appointment time with him, and we're getting band 5-6 clinical scientists to help support, physiologists to help support with the lung function tests. We do the bloods, ECG and X-ray same day if we need to. Andy insists on typing his own letter, which one day I will hammer out of him because it takes a lot of time to do, but it just helps him kind of write down what his thinking are and his thoughts. And to be fair, we don't tend to change the outcome very often. We then discuss every patient MDT and go through the clinical bit. So the way it works is good, and we're extending a number of appointments to keep up with demand. Next slide. Very complex, but mainly to say he sees the patient, we discuss it, and to be fair, MDT is a very broad view. It's two of us most of the time discussing these two patients, plus or minus cardiologists, but we tend to go to them outside. If the diagnosis is unclear and the initial stuff we've done, we then talk about further investigations, then we'll come back and discuss. Abnormal tests, we will tend to discharge with advice and suggested plan, but I will go over what else he does in clinic. Normal tests, we need to decide if we need more tests, etc., and any urgent findings. We haven't had any urgent findings, and I have a couple of people I've referred on to secondary care, but I can talk about those when we get to that slide. So we've had nearly 200 people referred. This is as of November. I think we've probably got to 200 now. 179 appropriate. There are more than 64% discharge. We are waiting. Usually we keep them on the books if we're waiting cardiology to see, just to see the outcomes, but they are discharged technically. It's about equal split, maybe slightly more female wise. The breathlessness can be anything between 8 weeks and 5 years, and the modified MRC dyspnea score, as you can see, there's division, but most are 1 to 2. Next slide. So Andy goes through questionnaires with them. We get an idea as a screening scale for anxiety and depression, deconditioning, and then we do 2 for breathing pattern disorder. It was our physio who suggested both. I'm still struggling to get my head about what one offers another, but we do it as trying to get an idea of that history taking and understanding if we think there may be some breathing pattern disorders. Most of these are self-reported, so deconditioning, it's very interesting that 72% say they're active, but even the people who are inactive are saying they're active, so it needs to be taken with a little bit of pinch of salt, but just as an idea when you take that history. But I think these are good for helping focus and remembering all of the causes of breathlessness need to be considered when we see the patients in clinic. Next slide, please. So initial triage, when we get those referrals, about 70% of patients have had an ECG, about 50% have a BMP, about 50% bloods, 1 in 4 chest x-ray. Ignore the bit at the bottom. Muscle tests I don't do anymore. I just find that it just throws up more questions than answers, to be fair. And the CPET stuff, they may have had something before and come through, but that's in the past, so they're the slightly more complex ones. 1 in 4 chest x-rays, it's interesting, isn't it? For someone with breathlessness, you think more chest x-rays should be done. I think that just needs to be considered. Next slide. Yeah. So then when we go on to further tests, about 42% have more tests than I initially said. So about 30% have in CPET, about 10%, so that's going to be 20 have had chest x-rays. I tend to request them if they've had low gas transfer or something specific, or maybe they've got the symptoms but struggling with lung function, because there are some people just can't do it. We've got mannitol tests that we do occasionally. Hyperventilation challenge, didn't even know existed. Our clinical scientists teach me every day. It's great. We've had about 1 overnight oximetry and very small amount of echoes, but increasingly CPET, you send them and it can tell you loads of stuff, whether it's cardiovascular, respiratory, deconditioning, breathing pattern disorder, and it's quite an interesting test to do. Next slide. So results from a lung function test point of view, we have about 2/3 are normal, about 25%, 1 in 5 have airways obstruction. Gas transfer is normal in about 2/3, and as long as static lung volumes as well. Pheno tends to be normal in a majority of patients. We've got community blood gases, very occasionally hypoxic, but also others that suggest hyperventilation, which is quite helpful as a supporter of the history and questionnaires as the bigger picture, not just on capillary blood gas alone. And for those who've had CPET, there'll be a lot more than 30 now, I think. We divide it into 3s, really. We've got 1/3 who've got evidence of breathing pattern disorder, 1/3 with deconditioning, and then we've got slightly less cardiac limitation. And I struggle with cardiac limitation because that can also be deconditioning. And to be able to tell the difference, I need a cardiologist to help me and look at the CPETs, and we found a friendly one that can help decide that, because we're not in a position to be able to go and exercise people and then repeat their CPET to see if it gets better. So that just helps. Next slide. Important are 65% we get people, we get everything done on a single visit, which is really important to bring them together. So Andy's done a bit of a comparison here. So pink, the lighter pink is CDC tests only. Slightly darker pink is when they needed additional secondary care tests like CPET, etc. And the orange is those who are seen in a general medicine clinic or respiratory clinic. So the referral to discharge, and it's days or weeks along the bottom. So referral to discharge is quicker, referral to clinic is quicker, and obviously MDT and triage quicker, but that will vary. And we've got an escalation plan if we need it, as more people are being referred and know about the pathway. Next slide. So outcomes. 50% of our patients have a primary respiratory cause, mainly asthma, COPD, couple of interstitial lung disease. About a quarter psychosocial. That includes breathing pattern disorder, deconditioning, anxiety and depression. And just to be aware, people can have a mixture of all, as we've already talked about. About 16 have needed ongoing referrals, mainly from cardiology, who, to be fair, cardiology haven't added and done a lot more investigations. Sleep clinic and respiratory clinic, I've just done a couple, and they're the specialist ones like ILD. We've got a few discharged with no clear cause, but we've discharged them because we're not able to do any further investigations because they may struggle with lung function, etc. But we've ruled out important things, and very few people have disengaged, and we're now getting feedback just to kind of help ensure that we make sure the pathway works for them. Next slide. So from a clinical scientist perspective, and we are looking, I sell this to ARTP, who are the clinical scientists professional body, and we're looking to do a community practice with them, because I think clinical scientists could be doing more, physiologists could be doing a lot more of these diagnoses. He sees the patient over a 30-minute consultation, used to be 9 minutes, but doesn't do the lung function tests. He does a clinical assessment. We talk about some management opportunity. Smoking cessation, he does referrals, he talks to them about. Breathing pattern disorder, he sat in clinic with our physiotherapist. We're not able at the moment to get a physiotherapist to sit in with a clinic, but would be massive, to be fair. And if the patient's from Wolverhampton, we can refer to physiotherapists, but if they're Cannock, we haven't got a physiotherapy service. So it's a bit postcode lottery, but because he's sat in clinic, he's able to use the right words. The breathing pattern disorder is really important, the wording and what you say. Inhaler technique, he'll go through breathing strategies and will refer on to a physiotherapy or health and well-being. So we've had those conversations, and he can do those referrals on. The clinical scientist does the triage, helps appropriate test bundles. We don't do all for everyone. He is working towards able to request chest x-rays. There is a limitation because they're not able to do any prescribing. So we're reliant on the referrals back to the GP to pick up the prescribing if need be. So there can be a delay, and the communication is really key with the patients and referrals in, and we make sure that's done as a regular. So there is some diagnostics, there is a lot of diagnostics, some management, but a lot we refer back. For instance, please follow the asthma guidelines to start appropriate treatment if need be. Next slide. So just coming to the end, next steps. This is now embedded as business as usual. So if a funding conversation comes up, yes, we've had NHSE funding for CDCs. So it came initially, and we've had further one come through. So that goes direct NHSE to that. What we've done is we've used our lung function managers, Andy, to see the patients, one because he wanted to and was interested to. My time doesn't take up much time and is embedded with some of the respiratory work I do, so I haven't had to ask for more than that. We need to be able to expand the capacity as it comes through. We have more waiting. We've got it's 40 patients waiting to be seen. We need to be able to expand and contract that as needed. We did go out, we do have to communicate regularly with primary care to remind them we exist, but I think we might be past that one now because they've got getting a lot of referrals, and obviously feedback from patients is really important to ensure that we've got this as best as we can. But actually, I think the way it works, particularly from referral to treatment time, is that direct referral in from our respiratory consultants and just bypassing the secondary care clinic unless we actually need it. And I think that might be my last slide, apart from questions, probably. Yeah, references, then questions. Cool. You can take the slides down. Thank you. Any questions for anyone? Thanks, Rachel. So different model to Rachel's, obviously in different kind of pathway or level at the pathway of when the patients are going in. But it's really good to hear about what everyone's doing differently. Francois.
Thank you both, by the way. It was an interesting talk. I got a question for you. So you've had, well, in the region about 200 referrals, 200 patients gone through. There's a very small number that you've referred on to cardiology or have had.
Yeah.
And I suppose that in a grand scheme of things, I suppose it's not a big number. And I'm querying whether, because it's a very respiratory heavy results base, isn't it? Indicating there's a lot of respiratory elements of things. I wonder why. That's my query and my question. Because you're doing all the cardiology investigations, it just doesn't seem many positive results. Are they getting filtered elsewhere? Are they getting filtered before this? Or is it just you're seeing more respiratory patients? That's my question.
Yeah, good question. I probably don't know the answer. My assumption was always, because BMP is readily available, that these were being done and filtered out before they were even referred in the first place. That was my one assumption. I haven't actually tested the assumption, I have to say. And also, I think the AFs are probably underestimated because that as a potential cause as well. But that was my thinking. But now Rachel's put her hand up, so she might have some different thoughts on that. Rachel.
No, not really. Francois, what's your background? Sorry.
So I'm like Andy, by the way.
He's
Andy. Yeah. So I'm
He's
an Andy.
Andy.
I'm a clinical scientist, also on HST.
Yeah.
So I do respiratory and sleep.
Great. I'm just making sure you're not an interventional cardiologist.
No, sorry.
I've been
Don't remember
teaching.
that. No.
And it's no disrespect to them either. They're amazing at what they do. Yeah, it is interesting. I also think there's this imbalance, shall we say, in what clinicians are worried about, what primary care are worried about, what patients are worried about, and what the actual problem is. So I think if you surveyed, I haven't, but if you surveyed the patients coming through to my clinic, what are they worried about? Actually, heart disease is one of the key things. And I think actually, if you're going to confidently exclude things, it's really important to have some link with the specialist. And the only reason, I know that wasn't your question, Francois, I just don't want people to see, oh, there's very little cardiac disease, you don't need them, because that's not the case. I think Helen's right that BNP, I think, does exclude a lot. And actually, if you look at what GPs actually organise, they do a lot of echoes. And for whatever reason, echo seems to be a little bit easier to get in the community in spirometry. So I think they're finding their own pathway. And the only other little bit of data, which isn't published yet, but I showed you, was actually in that pathway. Those cardiac investigations really only are adding really down the line that actually respiratory disease and other things are much more common. So that's where we need to focus.
So I'll be honest, my question is a little bit loaded. So we, in part of our pathway and developing our pathway, I'll be honest with this, we have a cardiologist who's got on board very early on. Now he's very adamant the idea of, when talking about numbers and patients, he thinks there's a lot of patients who actually will be more cardiology based. He doesn't believe it's potentially more respiratory than cardiology. And he's very much the mindset that a pro-BNP is very much like a dear dimer of cardiology world, effectively. It's very blanket and it's very much an arbitrary number a little bit in part. So it's very interesting when talking to him and discussing our pathway and developing our pathway, having his input's been really helpful, but also it's been very interesting to see the contrasting elsewhere in the country to see actually it's probably maybe more respiratory than necessary cardiology. And actually, is it more that cardiology investigations are a little more black and white and respiratory is a little more grey in part, and actually it takes a little bit longer to get
a bit more fluffy, yes.
A bit more fluffy, yeah, exactly. It's interesting. It's interesting, and I probably agree with you. The idea that probably the pro BNPs are actually filtered, and everything's probably filtered a little bit early on because the acuity of it may be that it's very done early on and saying, well, actually, this is probably more heart failure. Let's get straight into heart failure service. So it's interesting.
unless because if the feeling is that BNP takes out some but not all of cardiology stuff, are we underdiagnosing the cardiology? Because we say, right, BNP takes that bit out, but are there other stuff that we're not picking up that we should be? And increasingly CPET tests will come up with cardiac limitation, or sometimes their blood pressure goes up when they're doing, and we write to the cardiologist, does this mean anything? So we're picking up some from there, but if it wasn't for CPET, I wouldn't be picking up that much. But it's a fair review. But actually, in some ways, you want to keep the cardiologists involved, go through the system, go through the service, and see what the outcomes. Because if him being involved makes it look different to, let's say, ours, then we would need to go back and look at ours to see what was being done differently. Do you know what I mean? So I think that's an interesting thought. Thank you for that. That's definitely whet the
appetite. Yeah, thank you for that.
Yes, exactly. Thank you. Okay, Rachel, I appreciate it was put up, but I'm going to take it as a separate one, so I'll come along. So David first.
Just on the back of what you're saying there, Francois, I think it is interesting, because when you look at the slides what Helen presented, which, one of the first ones, it's got, the how much COPD is contributing to these patients, how much heart failure. You expect a lot more heart failure patient, well, not a lot more. You'd expect more heart failure patients being seen in this pathway than balanced with respiratory, but there aren't. It's very small. So it's like, what is kicking them out at the start, or are they not even getting anywhere close? And it feels a little bit like you're saying that it's probably easier for, not everywhere has spirometry and pheno and other things like that in primary care, but it's a lot easier to do blood tests. So is it that the blood tests are being done, the BNP is showing that these cohort of patients potentially have a cardio problem, so they go straight into the cardio pathway and not even enter any breathlessness? Could be something why there's that disparity when they're coming through, even when you've got, because that's why I was quite interested in asking Rachel. It's like, if you've got cardio and respiratory in this MDT, then you're still not seeing many cardio patients. Where are they going? Because partly it is, we're aware that not many heart failure patients are being picked up. We've got ongoing innovations and initiatives in our region to try and encourage and educate primary care what heart failure is. So it does get picked up a bit more, and it's maybe that combination of everything that they're not being seen, they're not being picked up earlier in primary care. When they are probably getting then positioned off into a heart failure pathway a bit sooner.
Yeah, yeah, definitely good thinking, and I think it would be good, Francois, for when yours gets going, or as it goes through with the cardiologist, see if the outcomes are different coming through the system. I think that would be an interesting to watch.
Yeah.
Nick.
Thanks. Sorry, two apologies to start off with. Firstly, I finished clinic very late, and I'm very sorry to be
It's been
quite so
recorded,
late.
Nick. You're fine. Don't worry.
So I look forward to watching the bits that I've missed back. Secondly, I'm afraid I don't have a camera, so that's the two apologies. And then one observation and one question. So just the observation about cardiac versus deconditioning. I mean, I think CPET has to be more about the 9-panel plot, doesn't it? And I think part of it is about what you see on the exercise bike as the patient transitions through to their anaerobic threshold and then into the higher echelons of exercise. And often you find that deconditioned patients will just go, I need to stop, I need to stop, I need to stop when they get towards their anaerobic threshold. And then you or the physiologist will just push them along for another 4 or 5 minutes until they genuinely get towards their VO2 peak. And I think that's actually, although it's very subjective, that's actually a very useful metric of telling whether somebody's deconditioned or whether they genuinely have a flattening of the O2 pulse because they've got cardiac limitation. So watching the patient on the exercise bike is as important as reading the 9-panel plot back afterwards. That's just my observation on that. My question really is more about those patients who have kind of blocked into a diagnosis of dysfunctional breathing and psychosocial reasonings. And I just wonder, do we have any data on how many of those patients come back afterwards seeking further explanation or feeling as though they need further input for their symptoms? Because I do kind of feel a little bit guilty whenever I give somebody a diagnosis of dysfunctional breathing, that I'm not always getting to the bottom of things. And for example, when the last patient that I remember seeing in clinic a couple of weeks ago who had clear evidence of dysfunctional breathing on her cardiopulmonary exercise test, actually was a lady who came from Iran. And when we went back into things in a lot more detail, she was told by her mum that she always had problems with her respiratory condition because she was subject to gases and chemical bombs from Iraq during the Iran-Iraq war. And I think it probably all stems back to that, really. So I think if we could go really deep down into some people's kind of psychosocial aspects, I think we can often find things that are triggers. And sometimes they don't have to be very deep triggers. And a lot of these patients I perceive have picked up a number of other diagnoses along the way, such as chronic fatigue syndrome, fibromyalgia. And a lot of them are probably have neurodivergence and have kind of small t trauma along the way, which has led to them developing a kind of phenotype of dysfunctional breathing, but that's not necessarily the underlying diagnosis. So I just wonder what work might have been done so far to look at those patients in more detail, and how many of them do you see actually coming back?
Good question. And I've just written down need to look. So I don't know how many have come back. And I think it would be because we keep all of our own data and patient lists, we can actually look to see how many coming back, ED attendances, re-referrals. We haven't seen any come back direct to us. But I think as an important question, that's something I'll look at. Now, interestingly, when Andy gets a feel of whether people have got a breathing pattern disorder by talking to them, he will broach that subject at the time he sees them. And I would suggest all but one have been kind of very open to hear what has been said. He tends to give them leaflets and a link to a video link if we can't refer to physiotherapy. There is one in particular just in the last couple of weeks who was adamant that Andy was talking medical term here, crap, and I think was not going to be accepting of it, but thankfully was we're going to consider referral to physiotherapists, and we'll see how that conversation goes, because he was adamant there was something wrong with him. And I think those initial conversations be really key, because you can't do it by letter, can you? You've got to use the right words. But I can't answer your question, but I'm going to get Andy to have a look into those patients to see what's come of it. Rachel, I don't know if you had any kind of experience with that.
Very anecdotal, Nicholas. So over 10 years, there's 3 people that I can think of that when they've had access to chest physiotherapy or rehabilitation, where that's just not cut it, it's not worked, and they've come back. However, I would say there's an awful lot where with my secondary care colleagues that try and refer in, and I just can't accept everyone, unfortunately. But that's where that diagnosis hasn't been linked to an explanation, has been found to be a little bit dismissive. Obviously, I don't know how the conversation has gone, but I think it's when it's not linked to the therapy that's actually going to help, that's where that disconnect, I think, happens, which, yeah, apologies, I know that's a very obvious thing to say, but is just what you see in practice. And Helen, and I suppose doing the long COVID clinic is very similar, isn't it? That when people are saying, if anyone says, and I'm not for a minute suggesting you do, but I know some of my colleagues, I can just hear sometimes that the conversation has gone on to that, but your tests are all normal, and it becomes a battle of whether symptoms are real. I don't think any clinician is ever saying that to a person, but that is just what they've heard, isn't it? So there's nothing wrong with me. Well, clearly you've got a very difficult symptom, and this is how we're going to get it better. But if that this is how it's going to get better is going to take 6 months, which it does in the long COVID service at the moment, it's a nightmare.
Yeah,
sorry, no, I was very waffly even by my standards.
But Nick, I will go back and ask the question actually, because we've kept a register or kept a link of everyone, so we can see who's been re-referred back, and we can actually see how many ED attendances kind of linked to it. So we'll get back to you on that, or I'll get back to you.
That's great. That's great, thank you. I mean, I agree, Rachel. We have a great physiotherapy service who are very happy to accept these people, and are probably quite overburdened by the number of people that I alone refer. And I do always try and, as you say, tie things from diagnosis to therapy as soon as I can. Do you have any other thoughts on things? Do you offer kind of self-help recommendations?
I refer them to the physiotherapy for bpd.org website, just because they've got some nice videos
Same as
and
us.
nice information, so that at least you've got something there and then, if there's not a physio actually in clinic. It just seems such a shame to me that you know, if you prescribe an inhaler, you get it on the same day, isn't it? Prescribe physio and you wait 6 months. It's yeah, it's the same up and down the country, unfortunately. I agree with what you're saying about an exercise test, and nothing beats actually watching it.
Watching it, exactly, seeing the pattern of breathing. Yeah, we either refer or we use the same link as you do for information, which seems to help.
Yeah, definitely. I was just going to add about the cardiology thing, about the rapid access chest pain service. So I know in our service there's a much more overlap than we would like. A lot of breathlessness patients get referred into the rapid access chest pain clinic and end up getting told what they don't have rather than what they do have. And I think some of maybe Francois, some of the patients that you're seeing in our trust maybe go there. I don't know. Well, I would say, I mean, we still do see a fair bit of fairly good going coronary artery disease within the service that go on and have intervention. So I certainly wouldn't want to be giving the impression that there's no cardiology disease, but I think they just have better you know, the rapid access chest pain service, BMP and community linked to an echo within a couple of weeks in most places. I expect that, whereas we're saying we can't even get spirometry. But it'd be worth mapping at someone's site what's happening in those areas.
Just add to that, interestingly, our cardiologist is the cardiologist who does do the rapid access clinic for chest pain. So, you know, he's that cardiologist who's in the back end of that, really. So, yeah, be interesting. I wonder where he's come from a different slant from that point of view, having seen those patients, really.
It would be great if he could collect the same data, whatever you're collecting in the breathlessness service. Sorry to give work to other people, that's terrible, isn't it? But if you could collect through the rapid access, because I think actually I think we've got people that go into that service that would be better in our service.
Yeah, so we're
but
doing.
It'd be interesting just to know who they get and what they do.
Yeah, because interesting. We're sorry to digress. So we're in the process at the moment doing an audit both of cardiology referrals and respiratory referrals to understand who's actually going to come and pitch into our pathway. Partly as a way of just gathering an idea for diagnostic capacity, really. But that'd be really interesting to see. I think it's a two-week audit, really, to understand how many come in. But that'd be really interesting to see, really, if how many are going to come from that side as well. So yeah, I'll let you know.
Because we certainly have some ping pong, and that really is inefficient. And when you're setting up to try and be as efficient as possible, makes me cry when people are still pinging ponging between.
Because patients at the end of it, aren't they? So it's not nice, is it?
Cool. Lovely. Thank you for that. Let me just apply to someone who's wanting me, but tough. Right. I have to say that was really interesting and really interesting discussions, and hopefully everyone's found that quite helpful. We've recorded it. There's slightly less of you able to attend this time than our last one. We've got one more community of practice planned in beginning of March. So if there's any kind of thoughts or things missed and you'd like to add, then please do let us know. We have recorded this, so please share it for those not able to attend the whole thing, because I appreciate we're running into clinic or late clinic, etc. And if there isn't anything else to add, Graham, David, anything else to ask just before we before we bring it to a close? I've got a no from Graham.
I'm sorry, I was going to mention action learning sets. We've got some, although we haven't got this community of practice until March, we've got some action learning sets next month in February. So yeah, please sign up to those if you're available and you haven't done us.
I'll share the dates out with those after this.
Cool, thank you. And the action learning sets, we're trying to do it so we can have that little bit more focused conversation. To be fair, we're getting that with some of the community of practice stuff as well. Graham's linking out with those that we're areas that we're not seeing as much to try and bring people in, because we just need to keep it going. It's end of January. It's been a tough January, still ongoing, but obviously trying to see where we're going and what the plan is at the next financial year, and hopefully some of this work will continue, but time will tell. But anyway, thank you, Rachel, for your time. Thank you for everyone else for their time. Have a good rest of the day, and we'll see you for the action learning plan, action learning groups, and also community practice at the beginning of March. So thank you all. Thank you.
Bye, everyone.
Bye.